Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. So this involves a patient who has been suffering from persistent otomycosis, so a fungal ear infection for many months, and I've treated them a few times, and I requested a swab culture of the ear just to confirm the presence of a fungal infection, because on their last appearance they had these really small yellowy green spores, which are very it's a landmark for Aspergillus ear infections. The other type of fungal infection that occurs in the ear are candida, so that's you don't get any fungal spores, you don't get any woolly filament cotton wool strands, but instead you get more of a thick, creamy discharge otorrhea. And the patient's GP took a swab and they confirmed the presence of Aspergillus flavus, which is not one I really come across. Normally it's Aspergillus niger that I typically come across, but this patient had Aspergillus flavus, so it's a different strain. And they saw an ENT specialist who's been trying to treat this for the last few months. And the ENT specialist advised that once they've got the infection under control, to visit myself so I can take ear impressions for custom swim moles, because as with any ear infection, you want to avoid water in getting into your ear when you're bathing, showering, etc. But prior to us taking the ear impressions, I had to remove a lot of this anti-fungal cream that was syringed into the ear by the ENT doctor, and it's been sitting there for a while. So if I took an ear impression straight away, it would just push all this cream that's lining the surface deep in the ear. So we're not going for we're not trying to remove every little aspect. So this is not infection. What you're seeing here is the cream. So it's not, you can't see any fungal spores here. In the right side, there was actually some granulation tissue, and I'll show you that. But I'm just trying to remove the majority of this cream that's been applied. It's been there for a while, so the ENT specialist is hoping that it may get absorbed by the epidermis, but if not, to request that I remove it for them prior to taking ear impressions. Upon attending, if we took that ear impression, as I said, it will coagulate all this cream and it will block the ear. In fact, they felt their right ear to be blocked anyway. I think some cream got lodged in the inferior recess, so once we could just clean that ear out, the majority of the cream, they were hearing a lot better already. You can see the underlying skin surface is good here. And that's all we had to do. We didn't, as I said, this is not an infection, it's the cream that we need to remove. It's mixed in with a bit of what earwax here. It's been there for several weeks, if not a couple of months. So it has slightly discolored. So we're happy with the left side. We took the ear impression there, and there was no problem. This right side, the skin, this patient just suffers from a high tenor of dead skin in any case, and it had mixed in with this cream and it just made it quite mushy, quite difficult to remove. The other side peeled away. You can see the almost like a skin peel on the left side. So, and I suspect it was a skin peel. So that cream had sat on that infected layer of skin that was colonised with fungi, and it was lining the ear canal. And when I removed it, that dead layer of skin that was previously infected came away. With this, it's almost like the dead skin is broken down and mixed in with the cream. Can get really mushy, but once we remove it, you'll see the underside, that the ear canal, there's a fresh layer of skin there, and it's infection free. It's the best I've seen the patient's ears, if truth be told. But this was actually affecting their hearing somewhat. So why do people suffer from fungal infections? Most commonly, the majority of ear infections are bacterial in nature. Probably about, I think, 70 to 80%. I can't remember the exact statistics, but we're looking around more than 2/3. You may have just seen that granulation tissue right in the centre of the screen at the moment, so it's slightly camouflaged by the cream. So the majority of ear infections are bacterial based, and fungal infections can occur secondary to a bacterial infection. So when you've got a bacterial infection and you take either topical antibiotic ear drops or systematic antibiotics orally, it can not only, of course, kill or inhibit the bacteria causing the infection, but it can also affect healthy bacteria. And when you've got less healthy bacteria competing in the ear, it gives the opportunity to fungi to colonize the skin flora. So the skin that lines the ear canal has its own ecosystem, and the fungi can colonize that because it's got less competing bacteria, and so you can develop a fungal infection secondary to a bacterial infection quite commonly. Of course, warm, humid conditions can all lead to fungi entering the ear and colonizing there. It just provides a perfect breeding ground. Your ear's dark, it's out of range and out of sight for UV light entering the ear that can sometimes inhibit the growth of certain bacteria and fungi, and they thrive in, of course, warm, moist conditions. So this patient has been getting water in the ear accidentally, showering and bathing, so we definitely need some chronic to prevent this chronic condition from escalating. We just need to get this sorted once and for all, and hopefully the ENT on top of this, which looks like they are, because the ear is the healthiest I've seen in a while. And by making some custom swim molds, it's going to help minimise the amount of water that gets into the ear. Now, if they do get water in the ear, even despite the swim plugs, it's recommended a hairdryer at room temperature if possible, not too close to the ear, but just to have some air passing across into the ear to dry it up. You can also use 1 part white vinegar, which is acetic acid, and 1 part rubbing alcohol, a solution. You can mix it and enter that in the ear. So what happens with that? The alcohol homogenizes with the water, and because alcohol's got a lower evaporation temperature to water, it evaporates out the ear. It's like when you use rubbing alcohol on your hands, it can get really dry because the alcohol evaporates, and with it, it takes moisture sitting on the surface of the ear canal or on other parts of the skin. And the acetic acid, it just helps to reacidify the ear. The acidity helps to inhibit fungal and bacterial growth. So there's a couple of things that the patient can do. Now there's a bit on the drum. So I'm just going to leave that. When we put the I'm going to hover over anything that comes away easily, brilliant. If not, we're not going to try and traumatize the eardrum. With a fungal infection, there's more of an increased risk of developing a tympanic perforation, so a hole in the eardrum, and that's because the fungi can colonize within the blood vessels and capillaries, supplying the bloods and nutrients the eardrum needs, and being starved of those nutrients and oxygen, the eardrum at the point where the blood vessels have become where it's occurred thrombosis, it can start to decay and lead to a perforation. So you can see there on the eardrum was actually moving whilst I was moving the suction probe. You probably saw some mobility there, so not much more we can do. We're on the eardrum already, and I'm gently gliding the suction across the surface of the eardrum, and the eardrum is physically mobile during that event. And if it doesn't come away, well, there's nothing more I can really do. Anything more I can do, it would potentially cause trauma to the eardrum, which we don't obviously want. So just to the back part of the ear canal here, just hovering over. We're on the bony part of the ear canal. So really gentle, just going to hover over. So with this amount of debris, taking the impression's it's not going to affect the impression taking. When we first examine this ear, so when we take an ear impression, I'll explain how we do it. We put either a cotton wool stopper or a foam stopper into the ear. It's attached to a piece of string, so we delicately insert that into the ear. They come in different sizes. And normally when we take an ear impression for a hearing aid, for example, we just want to go past that second bend, so more than a third into the ear canal. Because after the second bend, the ear canal straightens, and when we're making a custom hearing aid, for example, we want to know at which point the ear canal straightens towards the eardrum, so when the hearing aid is being manufactured, the sound ball can be aligned and configured for the individual geometry of the patient's ears. So the sound outlet at the tip of the hearing aid is being directly towards the eardrum as opposed to the side of the ear canal wall. With a swim plug, I generally like to take it a bit further, probably 2/3 of the way. So the back part of the oto block is actually making contact more or less with the eardrum, probably just prior to that, because we want a good, tight, watertight seal. So the longer it's in the ear, the better seal we're going to get, less likely water is going to be to enter the ear. So all the remaining debris now, even if we left it taking an ear impression is not going to affect this patient because we've got the majority of the occlusion out. So we put this block in, then you put some putty material. There's different types. You get additive impression material or subtractive. It's just different combinations of, so you get the main solution and you get one that stiffens it, hardens it. So it's additive or condensation silicone. I'm just trying to remember back to my university days. And so you essentially mix two putties together at normal resting state. It's like plasticine. You inject that into the ear. It's what dentists use as well, same material. And after a few minutes, that impression material hardens and stiffens, and we can then remove it from the ear. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.